So welcome everyone to the Research and Development Training Series run by the PSRC in Yorkshire and Humber. And this thankfully has been held virtually so that we can offer it to our colleagues across SafetyNet. And thank you very much to Mohammed for joining us today to present on clinical prediction modelling. And this is what he hopes will be an introductory session to the use of clinical prediction modelling in applied health research. Mohammed is an associate professor in the Centre for Digital Innovations in Health and Social Care at the University of Bradford. He is a colleague within the centre at Yorkshire and Humber and works with us on the safety intelligence theme. And I'll leave further introductions to him as I hand over. Thank you very much, Mohammed, for doing this for us today. And I'll hand over to you.
All right, thank you, Gochi. Yeah, so can you hear me okay? So, yeah, so as I'm one of the lead statistician for the center and working on a different, with a background as a statistician, so and working on a different aspect of the medical research. And one other thing, I got interested into the clinical prediction model, and this will be the more focus on some of the the practical aspect of the clinical prediction modeling, and also the one of the project I've been leading was about the computer-aided risk scoring system. That's actually there's a lot of names for the clinical prediction modeling in the medical literature. And so that is also a clinical prediction model example. So I will give you what is actually ended outcome of this is, and what this add into the clinical decision making. So this session will be mostly focused on what is the prediction modeling and how this is different from the causal inference, if you ever heard about that, and what does mean by the clinical prediction modeling really, and what are the phases of this, and some examples like the National Nivarni score and the computer risk scoring system that I'm referring to. So most of some of these examples this published in the well-known reputed journal, that is the consumption of the chocolate is associated with the number of the Nobel laureates. So maybe you have seen this before, but that is just a kind of correlation. They found the R is kind of correlation is if this R is 1 near to the 1, we say really high correlated. And it's positive means there's a positive correlation as you country consume more chocolate, and then actually they have a number of Nobel laureates are more as compared to the rest of them. So, but that is as a association. So, but there is no really any cause and effect really. For example, if the one country stop consuming the chocolate, doesn't mean that they will reduce the Nobel laureates. It's other way around as well. So that's we call there is some relationship of this is if you intervene something that will change the outcome. Or if you change input, will change the output as well. So I just initially want to discriminate the two-day talk is basically focus on the left-hand side, which is a prediction. But there is a whole domain of that is a causality, where you focus on the inputs and their data generating mechanisms. You can see how one variable is associated with other, and there was a link is subject specialist and how they are linked. So that's a totally different field to then what we are going to discuss today. That is, today is only about the prediction modeling, this focus on the output and how the output is actually, the predicted output is related to the observed output. And we're trying to mimic and try to produce some mathematical or magical equations will actually produce a generalizable results, they are sustainable, they are not vary across the different organization. They will be if you ever heard about the Q risk score, that is in the GP we use, in the UK we use as a Q risk score as a just to screen the people if they are whether they're on the risk of the like in next 5 or 10 years time on the cardiovascular disease, and so they screen them like based on their demographic profile. So that's the example of like the prediction modeling, traditional example of that. So we focus on the left-hand side, which is a prediction in this lecture. And essentially there is a lot of we can say in the clinical prediction modeling in a like more complicated ways. But the simplest way is like, this is a kind of mathematical equation. If you ever like read in mathematics in school, we say like the y is equal to a plus bx. That's kind of equation. X might be your input and then y is the output. That is as simple as it. So this equation is like we use in a statistics regression analysis method. So mostly we use that. But sometimes there is a clinical judgment as well. They can develop some scores. And in medical literature, we use these these models like for the either kind of diagnostic, diagnosing the disease, or you maybe the prognostic model, or you're modeling the outcome like the reoccurrence of cancer, or you something like the death, or those are the primary endpoints. So that is we call the prognostic modeling. And the diagnostic model, maybe you want to diagnose the cancer stage, or you want to diagnose the sepsis, or if you want to develop that is called the diagnostic. Essentially, we use the model like in the same way, but that is the two main areas in the literature that where we fit in these models. But there is a lot of research recently, like that population, and they're trying to before this this progress, which is basically a prognosis search strategy, like how you will find out which level this model is developing and how this will be useful. There was before publishing this, there was a lot of issues with the design. There was not really standardized. People are using their own way, and there was not really any mechanism. So this actually strategy has devised these models can applied in a different stage, either in the population level, like where you would like to diagnose the burden, and then might be some finding those biomarkers, like we say, maybe some risk factors, but we don't like the risk factor coming from the causal inference. We say the prognostic factor instead of that. But we're in the health research, we're quite used to use this term as a risk factor interchangeably. But where we are discussing that is a prognostic model research. To this is we are focusing on the prognostic one, where we try to find some prediction about the individual, like what is their outcome will be in some time limit, or how these are related. And then other way of is whether you would like to use for the medicine, the stratified, which person is actually needing the treatment and which is not. That is another area of that. So this is basically the ladder of those models where they fit in. So we are on the third step, there's a prognostic model research where these clinical prediction modelings are quite fit in. And there are different phases of this. And they're and these models are quite data hungry. There's not really in the qualitative studies. We use 20, 30, or 100 patients, we can get the data and analyze the data. But these are quite, as a quantitative studies, they need a lot big cohort, 20,000s, 100,000s, this kind of big cohort will actually produce a more generalizable prediction model. And when I use repeatedly the term generalizability, so that is one of the component of this model. Whenever you develop the model, it doesn't mean that this developed for only this organization. This is basically developed for some particular outcome. So it should be a generalizable from one organization to the other organization, or maybe one country to the other country, or one location to maybe if the model developed in some area where the white population is predominant, and then it should be able to apply in the diverse community we have in Bradford. So that is there's a lot of issues around there, how we will develop the model. So that's why we do the validation step. Like we try to take the data from the some development cohort and take something to go to the new cohort and see whether this model works in there. And we would like to evaluate their like the clinical utility, like whether there is some enough sensitivity, specificity. We do the like medical diagnostic testing, and we would like to see that whether these are useful. So these are the main area. There will be mostly I'm gonna be discussing each of them like in some of the detail, like what we are looking there, what does it mean by that. And before going there, like there's a lot of research like the first, whenever you think that I would like to do something, will develop some clinical prediction modeling, but then you ask again twice, like should we really need that new prediction model? So because there is a literature and there is a lot of models are developed, like they are developed and they are in the research papers. They never been go to the clinical settings. And they are still like, even if I give you the example of the COVID, during the COVID, there was like the 700 models were developed during that short period, just only for the COVID, for the predicting the mortality, are you predicting the COVID, using some X-ray data, using some other data. So they try to predict like that if this is a pneumonia, or yes, discriminate between the COVID. So, but then when we did the systematic review, so that is basically, you can see like whether this is really the evidence is there, like which model is really performing. And then there is only like the few of them, only literally found only the 4 models. They are somehow, they have some potential to be usable in a clinical setting, but the rest of them is like, it's kind of like full of biasness, and there's a lot of issues with that. So that's why we need to ask this question, like why we need this model, and then is there any model developed in this literature for this particular outcome? If that is the case, you can use that model as a starting point and start validating. So you need a big data sets and with some sufficient number of events. At least the minimum is the 100 events. Like for example, if you're looking for mortality, so you need at least data with some 100 mortality events with and without, so you can then compare something reasonably. But that is a minimum. It doesn't really stop you like that. You can add the maximum. There is no limit for that. So you need a large data if you would like to develop, and there is a lot of issues with that. So like once you are developing the model, and then the model is like how you make the model generalizable, and there is a lot of research on that. But the message is like whenever you are thinking about developing a prediction model, have a look at the literature and find out what is already around there. And if there is something, then start from there rather than developing your own from scratch. Because developing a one prediction model is like developing a new medicine. So it takes normally takes like decade or maybe more than that. So, and there is a lot of research on that, because there was not really a standardized, each person had their different practice. They produce like a different way of the performance measures. So there is recently, there's a push that they will developing some guideline. With one of the famous one is a tripod guideline with the prognosis and diagnosis studies, like what you need to report, like what is the sample size of that, which test you use. So everything you need to be analyzed, because it will be useful for the comparison, like the systematic review, meta-analysis, these kind of studies, and also with the aim to reduce the biasness that introduce unintentionally because of the reporting of the results. Maybe the studies there's a lot of biasness. And there is the ProBus tool as well that's to identify what biasness is coming from. Is about the outcome, is about the income, the input, kind of predictors, and is about the question they are asking. Maybe the question is different, is a causal question rather than you are doing the prediction one. So there's a lot of ways or your sources there where the biasness can introduce. So my magic box approach is just to intervene for this session. So this is just to show you what are the ingredients of these models are roughly really. So one is like the inputs are like the you need some kind of outcome where you would like to actually develop the model, and the some kind of inputs are your predictors, like for example demographic factors, socioeconomic factors, or other factors that are related to your outcome. You put into some magic box, which is just this green box is kind of magic box, like all those fancy names goes there, like the machine learning, logistic regression, deep learning, all these things are in this box. What they ultimately give you, that's the prediction about the risk of the disease or your outcome. So that is roughly the structure of this model is. So what you need as an input, you give to some software to say this is the out, they will just process everything and give you the output. But that's not as simple as it is, but it's just like the summarizing the way of like how this whole structure works. And we focus on the prediction, and we would like to see the performance of this prediction with the observed outcome, whether there is some good match, that means that a good model. If there is a mismatch, that means that this model is not good. And we normally use maybe you heard about the linear regression analysis. We use them like if we have a continuous outcome, let's say, for example, you would like to predict the length of stay in the hospital, like say HbA1c, or these kind of variables, we usually apply the logistic regression analysis. But in health research, what we have is a binary outcome most of the time. So we use like whether they have a case control, like whether they have with outcome, they have some event or not event, so they have some like the disease, yes, no, and these kind of events are the mostly we use a logistic regression. That is one of the name that's from the statistical modeling, like the clinical prediction modeling, most commonly we use. So our outcome is a binary variable, yes, no, and our input can be anything, continuous variable, age, height, weight, whatever those are associated to your outcome. So we use this most of the time. I will give you the examples of logistic regression, but there is no harm in if you're going to the fancy names. But in simple words, let's say we would like to predict the mortality, 30-day mortality in hospital, and based on their gender and age. That's the only two factors we would like to consider. And here we have outcome is like the mortality, and inputs like the predictors are the gender and like the age. And then we just give this to some machine, say that can you build a model, and then as an input and output, it will give you some output from there. But then its output could be a complicated. Like what we would like to fit is is a good one, that is it's a middle point, which is a good fit. Like this goes you have observed data, which is the blue one, and your dotted line is the black dotted line is going along. This is basically your regression, your analysis, your model, your clinical prediction model that is basically going along. If this is nicely go around those points, we say this is a model actually fit for that. But if it's on the left-hand side, it could be it's an underfit. It's not really representing anything about those fit. And it might be that this is overfitting or exaggerating the situation. That's what we call the overfitting. So what we would like to develop this model, we would like to avoid on the left-hand side and the right-hand side. We'd like to be in the middle. We don't want to add that much information. We'll be going to the overfitting or underfitting. And we evaluate these models based on some main pillars are like the discrimination and calibration. So what I mean by the discrimination is just like that. How well your model is actually can discriminate. If you can see there's the two distribution of that. One is the blue and one is a red. Like say what blue is a without outcome and the red is a with outcome. And if this is really sorry about it. If this is discriminating very well, then you can see on the right-hand side, we have an area under the curve, which is a AUC. If this is a 1, it means that this model can discriminate really well. And if this is a less than, it's a 0.5, it's just a tossing a coin. So it's not really useful. So we are only on the overlapping the both distributions. So this is one of the discrimination measure we use in the literature to measure the performance of our model, whether our model has any potential to predict that outcome. So if it's near to the 1, we say model is good. If this is near to the 0.5, we say it's rubbish. So in between, we are looking something above 0.8 or 0.7. So that is a reasonable model. Another thing is the calibration. That is basically how the prediction is actually aligned with your observed data. So that is the prediction of your outcome from your model, and that is one of the things we need to estimate if this is really good. Sometimes it's even there is a discrimination, but the calibration might be it's really worse as you go to the high risk group patients. So for the generalizability, so that's why we divided this validation phase into the different, we have a internal validation and the external validation. What I mean by that is the internal validation, it could be done in many ways, like the standard ways that we divide the data in 2 parts, and the first part is we develop the model, the second part can be used for the validation. That's kind of internal validation. But the external validation is quite in the last decade, we are really focused on, because of one of the problem with when there's people develop those, they remember the example of the COVID one, that they developed 700 models, but the very few models actually were externally validated. Most of them are internally validated. And the external validation is hard because you need to get the similar data from an independent site. Because one, you have the data side which you call the development side. You develop the model, but the second one, you need an independent side where you don't use anything in the development stage, but you just want to validate there. That we call the external validation. So if this is the externally validated, then model is really good. That can be generalizable to the other population as well. So this model has a potential. And we use a lot of these measures as well, when the clinician need to take the actions, we commonly use for the diagnostic testing, the same terminologies how sensitive this model is really picking the something adverse outcome, if there is a really adverse outcome, and then how the model is the specific, this really saying when this is no really means that there is no really any issue. So that the model means performing good. So if there is model is not performing good, then the sensitivity will be really low. The range of the sensitivity is 0 to 1, specificity is 0 to 1. So we're looking something with a high sensitivity and high specificity as we can. So there are a lot of other alternative to the logistic regression. So one of the study I conducted a couple of years ago. So there was even, in fact, is in 2020, there was published when we do that we say that the logistic regression is the standard one in the literature, but there is fancy methods as well, a lot of other fancy methods, kind of the machine learning methods. And we believe they pick more of the things from the data, learn from the pattern, those things. But we found when we do the external validation, logistic regression for predicting the mortality, logistic regression and those fancy algorithms are performing similar. So there is no really any issue. But in internal validation, you're just doing the internal validation, then machine learning is doing really overfitting. So it's actually giving a better results. So what is the problems that we can face during that? So one of the problem is because in a retrospective data, most of these models are developed on the retrospective data, EHR data, electronic health record data. So one of the challenges we face is the missing data. This data is because not meant for this research, but we are just using for the research purpose. So then we expect there's a data is missing. And this missing data is like the one of the hurdles or a challenge when you're developing the model. And there is this one of the review has been discovered that there's no really systematic agreement, like this people not really handling very well this missing data. And that is one of the challenge. Like when you develop the model, like for example, in the development side, you have like for example, one development side, they have a different policy, and compared to the other, like say NHS Trust, they have a different policy for the ordering the routinely like some tests, and some they order based on someone they just feel like they order all the tests, routinely collected tests. Some they only narrow down and they want to only selected tests. So this approach, this is not standardized approach. This is their internal protocol they actually develop in their own organization. So and then these actually standardization, I mean, this is one of the problem for the standardization. So this is not really like a similar approach on the both sides. Then they introduce the missing data. So this need to be the handled well when if we like to develop some generalizable model. And there is other issues with that, with the sample size, the people, and there is internal external validation issue I mentioned, and also how they transform the variables and how they explicitly report those variables, like the tripod guideline. So everything came together, how these things can be done in a systematic way. And how these, and the other thing is how these models actually align with the clinical judgment. Like, for example, we develop the model, it's been used in a practice, but how this is is it something like maybe because it's meant to be the sport, the clinical decision making might be just misleading the clinicians, or you somehow giving us some information which is not really right. So whether they have enough potential. And as you can see that we mentioned about the discrimination and calibration. So this systematic review have recently, they found that so these model has a really good discrimination. So they can really discriminate between those outcomes. But then what model adds is model give a better calibration than the standard clinical judgment. So in summary, the prediction, this research, there has these models are focused on the model development, external validation, and their clinical impact. And mostly these models are developed only on the development cohort, and they are really only focused on the development, not on validations. So most of the studies, there are very few studies, they have the external validation. I would say the 1 in 4. So, and then these models are developed, but they're not really updated. And then the very few are as I given you the example of the COVID, the 700 models are developed, but then who knows that how many of those will be really go to the as a clinical settings, use really in the action as the clinical settings. And their impact studies are really rare. So when they mostly because of this lack of this unstandardized approach, so when they go to the clinical, the RCT studies, they don't find any impact of those, because of the complicated nature of those systems, where they introduce. So then these were the technical aspect of that. Now I move to the some of the where this sit in in the clinical settings. As you know, that the one of the challenge in the quality and safety is the avoidable mortality. And so, and there is the most of these the mortalities are coming from the sepsis. And that is one of the as a clinical deterioration, how we identify the people in a complex environment where the clinicians are the full of workload, and they are how we can help the clinicians using this clinical prediction modeling to help them to make a better the decisions. and use the information that's already available, routinely collected. So one of the things has been used in developed in, I think it's 2012. We are all the NHS Trust. This was widely disseminated, and it was basically not a clinical prediction model. It was basically on the clinical judgment, and they found some penalty points based on the physiology of the patient. And they would like to monitor, provide a standardized approach where they can communicate, nurses can communicate with the doctors can communicate with the ICU team, and they can how the care can be standardized across all their levels. And one of the things they develop is a kind of, we call the national early warning scores, which are the news. So before that, there was 33 kind of early warning scores were developed, and then that was based on the data. But then the clinicians actually use that data and come up with this national early warning scores in the UK. And nowadays this is commonly used in all the NHS trust. And what they do is these are 6-7 physiology parameters, and if they are severe, if they are abnormal, they give us some penalty points depending on their severity, the 3, 2, 1. If there is a normal range, basically there's no penalty points, it's a 0. At the end, they sum up this score, and this score range is 0 to 20. And that's if the score is above 5, then the actually nurses approach to the doctor or a consultant, and then if this is above 7, then they approach to the outreach team about the patient. So, and they keep monitoring this. If this score is high, they have their own local protocol, escalation protocol, they call it. And they use this as a standardized approach to communicate and also to inform what decisions to be made. And it's monitored every, if there is a really high score, then they actually monitor in every 30 minutes. If the score is normal, then they actually monitor in 4 hours. So depending on the severity. So assumption is that these patients actually died not from their disease, but from this physiology. That is basically the main assumption. It says that if we actually work on the physiology, and if you treat that based on the physiology, and each parameter actually refer to the sum of the organ of the body, and then there is some clinical back of this as well. For example, how this can be an action, the first the patient in the morning, they have some kind of their physiology parameters, like the respiratory rate, oxygen saturation. If you put in the calculator, they say that the new score is 9, and there is some escalation that you have to. So this is really, person is really sick. You have to take the actions, and you have to take the actions really timely. And then once the clinical team, they took the actions, and the next 4 hours and 30 minutes, they measure it. And then they try to maintain their physiology, and it all went down, and their scores become 1. And so that is somehow this is kind of the trajectory as a time series thing, it's been changing a whole trajectory of the patient. And clinician can see the whole trajectory when the patient come in, their new score was high, and then how this fluctuate over the time during their stay in the hospital. So, and one of the thing I did was how these, because the clinician actually not really use this new score for the mortality, but what we were interested to explore how this is linked with the mortality. And on the y-axis, this is it is the observed proportion of the people who died in the hospital. And then the x-axis, this is the new score. As the new score is the 4, 3, 6, 8, 10. So that is as the score is higher, their proportion of the mortality is going high as well. And if you look at when the new score was 5, just in the middle of here. So after that, there's really the high peak. And after 7, this is really the steep increase in their mortality, because above 7 is really where the ICU team or your ITU outreach team actually approach. And this graph was really useful for the nurses. And before they were just saying that, okay, this is this is a protocol we need to follow. But when we tell them that there is like, if the score is above, then there's 10% chance of mortality of this patient is. So then they say that how this thing, they can link this new score with the mortality, and they understand the importance of this as well. And this is now part of the one of the York Hospital Trust, like the nurses, like the education. And we know that there is no wonder like that as we get older, then the mortality is increased because of comorbidities, like a lot of other medical conditions or chronic conditions that we have. So, and then we can like the further explore. So this is this stage is basically like the initial stage of finding those prognostic risk factor, like identifying which factors are associated with the mortality. And one of these are the parameters that is on news, national early warning scores have this parameter: respiratory rate, body temperature, systolic blood pressure. These are commonly collected. And we look at how these individual parameters are associated with the mortality. And we can see as this respiratory rate is high, then their mortality is high as well. And this is you can know that this is a respiratory rate is a part of the infection, like this kind of indication of the infection, like the body temperature, either it's a low or a high. This is the both sides, the mortality is high. And there is a systolic blood pressure, pulse rate. So this is the kind of relationship between those, our input, like the one of these variables, with our output, which is the mortality. And how we can combine this. So we then ask for our magic box that we want to put this into the model. Can you make the equation? So they make this beautiful equation. This is not for the human consumption really. So it's just, I don't want to scare you, but it's just how the model will be ended up, like that they will give us this kind of like the window where you can give us some factors, like some variables to multiply these things. There's all the fancy things are going on the back end of the thing, like this clinical prediction model. So this is basically the actual face of the clinical prediction model. We don't see often this, but what we see often is like if I can show this, like the example of the cars. I don't know, I have to share the screen in some way here. So. Can you see the screen with the cars calculator? It's a blue one.
Yes. Okay.
Yeah. Okay. Thank you. Yeah. So that is basically the face that we look at the most of the time. Like that was that equation was this will translate into this human readable calculator. And that is that's the cars calculator we developed that based on the physiology, how we can predict that. Like, for example, if we were to say that someone is with the age of 75, gender female, and their respiratory rate is 22, oxygen saturation is 96, and their oxygen supplementation, whether they are on the oxygen supplementation, yes, no. If we say yes, and let's say their body temperature is 36, systolic blood pressure is 120, systolic is 80, and we have a pulse rate, let's say 75, and they alert. So what it does is it gives us some risk here. That's the ultimate outcome of that. All those clinical, that model will give you there is the risk of this person is the sickness profile is 10%. So what we found is if this score is above 8%, it means that the clinical team has to take an action on that, that's statistically. But if this is up to the clinician, they look at the individual factors and they think okay, whether they would like to take an action, are they already intervene, they have already taken the actions, this will take some time. So then this is up to the clinical team that how they decide. But what the information this model has taken, it shows you that this is the chance of the mortality, and the 25% chance this person is a sepsis is suspected in this person. So this is the example of the diagnostics modeling, and this is a example of the prognosis modeling where we are actually asking for the mortality. So the same model is like this model is trained on the different outcomes. There's a different equations for each outcome. And then we ended up with this examples. That is basically, and then at the end, they will show you that those new score is 5, which is remember there is some threshold. The variation from news is 0 to 20. That's the new score. And the 5 is where the nurses actually take action to ask to the consultant whether they need to take an actions. And the disparity rate is like the 2. And then we have oxygen saturation. And then this is useful for the clinicians. They would not also look at this. They will also look at this as well. See which factors are actually contributing to this score. And that's whether they have taken already those actions, or they need to take further actions, or maybe they need. So that depends on their clinical judgment. They just to support them what the data they have is about the patient and how this is useful. And what else we did is we actually added more to the new score. We added rest of other things as well, which is routinely collected, which is like the pathology results, like the hemoglobin, white cell count, creatinine, these variables. We added this and we found that our model is quite sensitive to actually identify those patients. So that's an example. That's basically the final outcome of this whole clinical prediction model. Let me go back to my slides. Yeah, so that is essentially what we are aiming for. And with this, this model, we have an area under the curve is 0.82. Remember, if this is near to the 1, is really good. If it's a 0.5, is rubbish. And in between, there's something above 0.8, so we can is eligible for the clinical settings. So these models are they develop in some the scores, and they are also implemented into the hospital settings. So these models were implemented in a York Hospital, and even during the COVID, they have been used to actually diagnose. And then we found that the septic equations is basically more useful for the diagnosing the COVID patients. And then the mortality one is about the mortality. So that is there is the internal biological pathway as well, how the sepsis and the COVID were related. So nowadays there is a more advanced stage where we are living in the era of AI and the machine learning. So there's a lot of that people are trying to find those nonlinearities and trying to find out using those modern machine learning and AI methods. And one of the approach has been recently published that based on these early warning scores, they use some deep learning, these kind of models that using that black box and try to interpret those black box. They found better the area under the curve, so that they call the DUSE, which is kind of the deep learning based of algorithm. And then there is the more to uncover really how these AI can uncover. Maybe the kind of the ChatGPT. They have use the maybe you heard this news. It's I think in states they have one of the frustrated mother. They put the child was had some kind of rare disease, and then she has been to the 20, I think, the doctors, but then none of them able to diagnose with that. And then the mother was really frustrated, and she put all those reports on the ChatGPT. And then the ChatGPT actually diagnosed that, and then they've been to the doctor, and the doctor actually or agreed on that, and they treated them, and then the kids were like survived like with that. So that is something like to uncover in a clinical prediction modeling more with the time, like we'll see like how these physics can be improved. But remember that this is one of the examples, but then it's AI, like there's a lot of issues with the AI as well, like the AI biasness, AI hallucination, and sometimes this AI try to give you the answer, but it doesn't really make any sense. So there are the issues as well. So what is, I can just recommend some of these books, really quite, I think that this is a whole, like covered like the most of the things, like on the left-hand side, this is really the good, like the introductory book on the clinical prediction models. It's written by the Strijberg, who is a professor in medical decision making in Netherlands. And he has, I think there is a pioneer in terms of like the introducing this clinical prediction, and there's a lot of contribution from him. And then there's a Frank Herrer from States, who did on the regression modeling strategies, a lot of applied work on that. And Richard Lay, who has published a book on that is more focused on the prognosis research in healthcare. So these books are really cover the most of the contents that related to if you want to dig down more on the clinical prediction models, would like learn more about that. Thank you very much. And if you have any questions, so I hope it makes sense to you.
Thanks, Mohammed. That was great. That was an excellent run through what clinical risk prediction tools are and how they're developed. And I love the examples that you gave. So it's a really good presentation. Has anyone got any questions? Please ask now, or into some in the chats if you have anything you need to ask. Jen?
I honestly, I don't know why I've come up as Josh Granger, but
What's the
anyway, I think I do know, but yeah. Thanks, that was really great actually, and really understandable for somebody who's pretty clueless about this. And it's really good to be reminded about, you know, what positive predictive value means and all the rest of it, sensitivity and specificity. So looking at the news score, and you're going to have to excuse me, I'm pretty ignorant about stuff like this, but things like looking at news score. So in the PSRC, so I work in Yorkshire and have a PSRC as program manager. So in the PSRC, we've talked about developing vulnerability indexes, in particular looking at safety equity. But I'm just wondering, when you look at the news score and it has things in there like oxygen saturation, and I'm thinking about how they measure oxygen saturation and whether there's any inequities around that side of things, and whether there's an advancement on things like you know, skin color, for example, when you're measuring things like that. Is there any movement in terms of these sorts of clinical risk prediction models to include things like that?
Yeah, it's a really good question. So it's like so that's what we call the kind of like the algorithmic biasness. So there is a transportability of these models. And then you're right about based on the skin color, those devices, like the oxygen saturations, they produce the biased results. So but in the clinical prediction modeling, so we don't really worry much about that kind of biasness, like on those observations, because the predictions couldn't be based on what are the health disparities exist in the system. So it's taken account, or you try to get those all the relationships between those variables. If there's a variable is they have a variable has some kind of biasness towards that. For example, one of the things we found in the literature is the disparity rate is basically is a more even rather than odd. So, and you understand why is that? Because most of the time, nurses actually only calculate for 15 seconds and multiply by 4. So that's how this is, because when you look at the data, there's a more even data and rather than the odd. But in terms of the prediction, it doesn't really impact on the prediction. So when we go to develop the models, it doesn't really impact on the outcome, or because you remember, when we are talking about the clinical prediction, we would like to evaluate them in terms of discrimination, how well this can discriminate between outcome and not outcome. So this is relatively a minor thing for the predicting the risk. But that is a more like when you're looking at the causal side, people were really keen to, if they would like to keen on the inputs, then that is the area basically more explore on that area. Like looking at the inputs, are they looking at we say the measurement errors, like that. And these are even these models can introduce the health disparities. Like if we develop this model in a York hospital, and I would like to develop, let's say, validate into the Bradford, we don't know how this will behave here because it's a totally different population, different way of their understanding those healthcare. So there's a generalizability of that. Yeah, the inputs are, in summary, the two inputs are really related to the causality domain. So we are focusing on the output, and these little things in the inputs doesn't really make huge difference in terms of the output.
Thank you. You can stop sharing your slide as well if you want, so we can see everybody.
Yeah, I can. Yeah.
Thank you.
All right.
Thanks for that answer, because I did have a question in mind about measurement error for the respiratory rate, because that was I thought I'd had. Sasha, you had your hand up.
Yeah, I'm sorry. Sorry, I'm late. I'm new to the university, and can you hear me?
Yeah.
Can you hear me? It was just I'm from the School of Nursing, Public Health and Healthcare, and I was just wondering, did you all introduce yourselves at the beginning and I missed it?
No.
Because
No.
I'd be really interested to know where everybody's coming from in this audience, because I think what I hear is like almost like a statistician's view of like some of this, but then also like we've got nurses that can actually input this element of the questions that you're asking. And you know, I did roll my eyes when you said about the 15 minutes about respiratory. I mean, yeah, so there is some practices as well that are different across the piece. So I suppose my question is where everybody is in the room in relation to what you've just said, because I found it fascinating, but I also think we're in a privileged position to look at this from a variety of lenses. So that was my question, really.
Yeah, so this like the models, like what we develop in the observe in the data. So I mainly sit in the health studies. So it's a center of the digital innovations in social and healthcare. So and then there was the more of the service users from the health studies, like the nursing groups. They were involved like in the development of this scoring system, and these questions are basically raised by them really to actually how we will present these scores. It will be a percentage, it will be a score with some emojis, or it will be like the red color, green color. So there's a lots of questions about the disparity questions even come from one of the nurses. They would like to see how this impact on the prediction. So, and there was a lot of involvement from in this work was from the Improvement Academy and also from the PPI in BIHR, Bradford Institute for Health Research. So there's in the PSRC, PSTRC, before that, now it's a PSRC, and before it PSTRC. That was one of the this was recognized as one of the main project for that project. And there was a lot of force from there as well be used at here. So that's one of the,
yeah. And how does it fit into the big, so sorry, I missed the first 5 minutes. So if it was mentioned there, how does it fit into the big national program of looking at news and Pews?
So the Pews is for the kids, like the pediatric.
Yeah.
So this is the work we did is we combine the national news score.
Right.
That's a simple thing. And we combine with the pathology results, all the creatinine and these, those are the 7 blood test results.
Sorry. Yeah, I meant there's a national was this research funded by the National Institute to look at this, because there is some ongoing work?
It was funded by the Health Foundation. The
Right.
original work was funded by the Health Foundation.
Yeah.
But then this was like acknowledged by the PSTRC, which was a NIHR previous, like the
Right.
Center for Yorkshire Amber Center. So they have also acknowledged that as a project, but like I said, because they were looking at the different projects in the team. And then, so we, this at the moment, there is no funding for this project. So this work has been already implemented. So we are at the moment, we did some service evaluation of this work, and also see how this is helping the clinicians, how many people are really would like to, they are already
Right.
using in this busy schedule. So
Yeah.
there's a lot of the qualitative work around that.
Yeah.
I haven't shown it because this is only 1.5 hours. I can happy to discuss with you and arrange another meeting,
Yeah.
because you are based on the same faculty. So give you more
amazing. Amazing. Thank you so much. It was really interesting. Thank you.
Any other questions? Just out of curiosity, Mohammed, I was amazed by the number of clinical risk prediction tools developed during COVID. If anyone missed that, was 700, you said?
Yeah.
Is there any other clinical area where it's a little bit overrun by this kind of development of a clinical risk prediction tool? Why do you think it is that people need to keep creating their own rather than?
Yeah, I think that would be the really interesting question to ask as a researchers. But I think that what I feel is because it's quite easy to develop the model. So if you if you get access to the sum of the data, what they feel is why not we develop the model? But very few models they even do because they only reach to the first is just internal validation stage, and they don't even go to the external validation because they don't have a data. The data is only assessed to the sum of the area. And the clinician found, okay, we can develop this model. And then with that, they just did it, but they don't really interested in the utilizing the before models, whatever the model developed. So that is basically the behavior of the model development, because there is a lot of people are coming from a computational background and they like to develop the models. But they don't know, their no aim is not to actually implement in a clinical setting, is just to get the publication right and just to publish it. But then after that, nobody knows where this model goes, and there's no really any other things. And then the most of the thing is and the very, very rare is that the models are developed with a PPI involvement. And because of, that is one of the core part, without that, you cannot develop the model in your desk and say, okay, I developed the model, can you please use it? No, they're not going to use this model anymore. So because they would like to develop something that their voice is, with the patient voice. And so very few models. I think that I would say the 1 in 1,000, they might have a PPI component developing that. And it was quite rare that these models are. So, and if you see that so far, we have, I think the good examples are the QRisk, ARIA ICERIC, ARIA. So there's if you count them on fingers, you can count them on a fingers, which are the successful examples of that. But the rest of them are it's a massive literature on that, and very few actually develop on that.
Thank you. Any other questions? Mohammed, would you be happy to share the slides?
Yeah, I can share the slides. These are already published material. No issue with that.
I think the recording also will be shared on our YouTube.
Yeah, that's fine. So
Yeah.
it's good to have if there's someone finds it interesting, that's fine.
Yeah, because I think there was some links, some very good resources, so that'd be really great.
Yeah.
If there are no more questions, I'd like to thank you very much, Mohammed, for delivering a really talk to us. And that's just great start to the new academic year. And we have monthly research development training sessions, and most of them will try and make available across the safety net, across the 6 PSLCs. So thank you, Mohammed. If I, look out for links for other sessions, and we could see you again, and hopefully they'll be as useful as this one. Thank you.
Yeah, that's good. I think that in terms of the weather, it's not a good start, but otherwise it's okay.
Yeah, indeed. Thanks, everybody.
All right. Thank you. Bye.
Mhm.